We are going to be recording, so if you don't want to be recorded today, please exit the call, and this will be available on the ASAM transition website later on this week. Thank you, Gloria. Appreciate it. All right, everybody. So good morning. Thank you for joining us this morning. It's so nice to see such a large group on here. Really appreciate everybody taking the time to join us today. My name is Kathleen Hoagland, and I'm the Program Representative Supervisor in the Division of Program Support and Quality Improvement at DDAP. And we are going to be talking today about some ASAM myths and facts. And hopefully what we're going to go through is going to be helpful to everybody joining the call today. So just a couple of reminders. This call is being recorded. So again, if you don't want to be recorded, this is your opportunity to exit the call. And this content will be available at a later date on the ASAM transition website. And so for future reference, we are going to continue these calls for the next couple of months here, and I'm going to talk about kind of the larger plan here in a minute. But if you have questions on the topic that the call is going to be focusing on, please submit those 7 days in advance to the ASAM email account. And questions will not be addressed during the meeting. So we encourage people to put questions in the chat box during the presentation today, and we will be answering those at a later date. We will not be answering those live. And any suggestions for future call topics are always welcome, and those can be submitted to the ASAM resource account, and the email address is noted on the webpage there. All right, so just a disclaimer here, the ASAM alignment is required of drug and alcohol treatment providers that receive funding through single county authorities and managed care organizations. And the information presented here today is just an overview and a summary, and it does not substitute actually reading the ASAM criteria 2013 and attending those ASAM trainings. We cannot stress how important that is, and we really encourage folks to kind of take out the textbook, which I have handy here, take it out, read it, and you know, from cover to cover to understand the ASAM criteria 2013 at its core. So please. To go through the text and attend those trainings. I wanted to take just a moment today to kind of step back and look at some of the topics that we've covered over the past 6 months. And I just want to let people know that we started this in October of 2021, and the plan for this, the ASAM Monthly Technical Assistance Series, was for this to be a time-limited series, and that still is the plan. So we plan to run these until the last one will be in September of 2021 or 2022. I'm sorry. And so it is time limited, and that was always the plan. And I just want to say that it has been so nice to see the participation in these calls. Every single call that we've had going back to October, there's been 100 to sometimes 200 people on these calls, and that is just really, we just really thank you just a lot for being here and for taking the time to attend these. It's been a really nice surprise to see that level of participation. And so we just want to, you know, again, just provide an update today. So these are the topics that we've gone through over the past 6 months. You know, we're going to continue these for the next 5 months or so. And so if you do have suggestions for topics, please send those to the resource accounts. We really want to encourage that. And my hope for the remaining 5 months is that we will be able to be a little bit more interactive in some of these discussions. And I'm going to try that out a little bit today, and I'll talk about that in a moment. So again, we just want to say thank you for being here and for taking the time every single month to join us. That really just says a lot about kind of the motivation for implementation of ASAM and wanting to learn more and understand ASAM better. So thank you. All right, so like I said, we're going to be going through ASAM myths and facts today. And so basically the learning objective is to identify some pretty common misconceptions and understandings related to ASAM. And we're going to be going through 10 myths today about ASAM alignment. And so we came up with these myths by looking at content from emails that we've gotten from providers and from stakeholders, or just general statements that have been made during technical assistance calls or conversations. And that really, it helped us to kind of understand some of these trends that we're seeing with some of these misconceptions and maybe misunderstandings. And so we hope that today, what we're going to go through is going to clear up some confusion and offer some clarity. But again, like I said, I also would like to, maybe try to engage in some dialogue today and get some feedback from providers and stakeholders about some of the things that we're going to be going through. So again, this call is going to be a little bit different today. I'm going to try something new. This might work, it might not. We'll see how it goes. But I'm going to ask for a little bit of participation from the group and, with certain slides. And so right now, everybody is muted. But if you have a slide where I ask for participation and you would like to try to offer some feedback or an answer, if you wouldn't mind just raising your hand. And if you can look at the top of your screen, there's a reaction button with the hand raise. You can just press that, raise your hand. And we're going to try to call on folks today, and I will unmute you. So again, this is something new. We're going to give it a try today. We'll see how it goes, and just really encourage you to participate if you can. And also for a little bit of patience as we try out a new approach today. All right, we're going to start to dig into some of these myths. So myth number one is that ASAM alignment is not a requirement. It's more of kind of an optional thing that providers can do. So I'm here to tell you that ASAM alignment, it definitely is a requirement, and it's a requirement for a couple of different reasons. And the first reason that I'm going to go through today is where kind of ASAM all started. And I do want to give a little bit of history. So if you can just bear with me, I do think it's important to just review this because I think it really helps individuals and providers understand better why we've done what we've done in terms of ASAM alignment, and that there is a really specific and very good reasons behind the transition to ASAM. So essentially what happened is in May of 2016, the Centers for Medicare and Medicaid Services issued a final rule that overhauled Medicaid's managed care delivery system. And essentially, this rule kind of prevented states from receiving federal financial participation for Medicaid enrollees receiving inpatient treatment at an institute for mental disease. So this is also known as an IMD, so an Institute for Mental Disease, IMD. I'm going to say this a couple times, so I'm going to be using IMD for more than 15 days during the month. So it's important to note that these IMDs, they include substance use disorder treatment programs, and more than 80% of Pennsylvania's treatment facilities fall into that definition of IMD. So what happened here is that this really did put the Commonwealth at risk of losing $55.5 million if this IMD issue was not resolved by a specific time. So that was July of 2018, when the ruling would go into full effect in Pennsylvania. And so as a result, obviously, Department of Human Services applied for a waiver to CMS under 11 and 15 of the Social Security Act to help mitigate any financial impact that this would have on Pennsylvania due to this rule change. And the initial CMS guidance regarding the 11 and 15 SUD demonstration regulations, and while that requirement was later revised, there remains a requirement for states to utilize an evidence-based multidimensional treatment guideline. So for us, then that was ASAM, the ASAM criteria, the American Society of Addiction Medicine. This is an evidence-based template to determine the appropriate level of substance use disorder intervention for an individual. So that is one of the main reasons for the transition to ASAM. And I feel like it is important to go through that once in a while so that folks are reminded of kind of the history of this. The other thing I just want to note here is that in addition to the 11 and 15 waiver and the role that played in the transition to ASAM, Act 70 was passed this past summer. So in the summer of 2021, I'm sure a lot of you remember this. The exact verbiage in Act 70 states a drug and alcohol treatment provider shall align service delivery conditions with the American Society of Addiction Medicine, 3rd edition, 2013. So as many of you recall, Act 70 also allowed providers an extension to come into alignment through December 31st of 2021. So obviously that time has come and gone, and we're kind of in the full implementation mode at this point. So ASAM alignment is a requirement, and those are the reasons why. All right, so myth number two. And again, I just want to remind folks where these myths are coming from. So these myths are coming from conversations that we've had, questions that we've gotten into the resource accounts. And it's these are usually topics that we've seen many times. So it's a pattern that we've seen. So this myth is that ASAM does not recognize the importance of AA and NA and other mutual aid recovery groups. So this is absolutely false. ASAM recognizes the importance of these groups. This is evidenced throughout the ASAM text. And I just want to note that self-help and mutual aid groups are referenced 26 times in the ASAM text. It is absolutely identified as a critical resource. So one of the most important places in the text I would encourage folks to look at to see kind of what ASAM states about 12-step and mutual help groups is on page 108. There's a really helpful table that I would encourage everybody to look at. ASAM does really specify that while these groups are absolutely critical, it is not considered a skilled treatment service. So, ASAM talks a lot about kind of 9 to 19 hours of skilled treatment services or 20 or more hours for skilled treatment services. So these groups are not included as a skilled treatment service. So they do not constitute formal treatments, but they are absolutely critical and extremely valuable to integrate in all levels of care. And as folks move along the continuum of care. And obviously, when people are not involved anymore in formal treatment, it is absolutely critical as well. So I'm just going to pause here. This is my first attempt at asking for a little bit of participation, and it's not going to be the kind of participation where I'm asking you to unmute yourself. But if you just want to type in the chat here, I just want to gauge everyone's understanding of 12-step and mutual aid groups as they relate to the 6 dimensions. So if we're asking an individual about their history of engagement with 12-step and mutual help groups, which dimension are we kind of addressing the most? So if you just want to take a second to type in the dimension that you feel like really touches on this the most, that would be great. And I'll just give everybody a minute here. So again, this would be the dimension that addresses things like support systems, resources for recovery, okay? Yep, good. All right, I got some participate. Thank you for taking a chance on this. Yep, absolutely. So that would be dimension 6. Perfect. Thank you, everybody. That helps. Absolutely. Could be a little bit of 5. All right, very good. Excellent. Thank you. Thank you. And so the other thing I just want to mention here is that obviously, just like everything else with the ASAM, it's really important to individualize care in every aspect. And so what that means for gauging somebody's interest in recovery groups is asking what they would want, right? Like what groups have been helpful for them in the past? What are their belief systems? What are they interested in? So we know that there are many options right now. So there's 12 steps, there's smart recovery, there's celebrate recovery. And if anybody has any other suggestions of other recovery support groups they want to type in the chat box, that would be much appreciated as well. So any other, that I'm missing here, please type those into the chat box. I know there's Double Trouble. There's a lot of different options these days. So again, that should be individualized as well. AA and NA is obviously not going to work for everyone. It's going to work for many people. Smart recovery may not work for everyone. They may want AA and NA, or they may do better with AA and NA. So again, this has to be individualized as well. And I'm just going to take a second here. I think everybody can kind of see the slides. Yep, good. Thank you, everybody. I see some other options in here: refuge recovery, ACA. Very good. Okay. Thank you. That was the first participation. That went well. All right. Dharma recovery. Very good. All right. So myth number 3. So this has been a really popular one recently. So ASAM level 3.7 is the same as ASAM level 3.7 withdrawal management. Been very popular recently, and so just wanted to take a time to address that today. So I kind of laid out here some of the differences, but really fundamentally, the range of therapies that have to be offered at ASAM level 3.7 are much greater than those offered in the withdrawal management level of care. So In 3.7 withdrawal management, there is still therapy offered, but it's offered as clinically necessary or appropriate depending on that individual's progress through their withdrawal management. So in other words, the focus on 3.7 withdrawal management is really getting that individual safely through that withdrawal management process, introducing some therapies, and hopefully preparing that person to engage in kind of more treatments, maybe a step down to a less intensive level of care, maybe a transfer to a 3.5, once they stabilize, or a 3.7 withdrawal management to a 3.7, but absolutely two very different levels of care. So 3.7 is medically monitored intensive inpatient services, and 3.7 withdrawal management is medically monitored inpatient withdrawal management. So two very different levels of care. And I always encourage people to look at the pages in the text. Really, the best way to understand the differences here is to read that 3.7 chapter. I have the pages here, and then to read that withdrawal management chapter. And you will very clearly see the differences between these two levels of care. All right, myth number 4, ASAM alignment review will occur during DDAP licensing inspections, or all the SCAs, BIMCOs, and licensing inspectors will be coming to our facility to monitor for ASAM. So this has also been a very popular one, and I understand why this is such an interest to programs. I definitely understand that. So we wanted to kind of clarify that a little bit today. So to make it very clear, licensing inspections and SCA provider monitoring are not changing because of ASAM. So again, licensing inspections and SCA provider monitoring are not changing because of ASAM. Licensing inspections occur annually and can be unannounced when investigating a complaint. They will continue to focus on what they've always reviewed. A licensing site visit will continue to include chart reviews, review of policies and procedures, a review of physical plant standards per the regulations. That is not changing. The SCA provider monitoring will continue to focus on a review of the contractual requirements through pre-submission documents of policies and procedures and on-site chart reviews. So that is not changing. And then DDAP and DHS, in terms of the ASAM alignment reviews, DDAP and DHS are working with the SCAs and the MCOs to develop a consistent process for ASAM reviews. So this ASAM alignment review will be collaborative, in which the SCAs and the BIMCOs will work together to review whether a program is providing services in line with what the ASAM text requires for that specific level of care. So hopefully that offers some clarification for everybody. And again, these slides are going to be available on the website probably by later this week. And so you'll be able to see this for yourself and to use this as a reference in the future. And so the next myth I have is related to this, which is myth number 5. So, have heard that a lot of providers maybe just feel like they're in the dark about what to expect with the ASAM alignment review, or they have no idea what to expect with the ASAM alignment review. And the reality is that the ASAM alignment review is again, it's going to be a process in which the SCAs and the BIMCOs will be working together to review whether a program is providing services in line with what the ASAM text requires for that specific level of care. So in terms of what you can do to prepare, you can do a lot. Being here is one way that you can prepare for that. So that is a big step here. Again, reading the ASAM text, start to finish, attending ASAM trainings, reviewing the level of care specific service characteristics on the DDAP ASAM transition website is a big resource. Asking for help. So if you're feeling stuck in a specific area of preparation for ASAM alignment reviews, email us at the ASAM resource account. That's what we're here for. We're here to help. We're here to help prepare people for that. That's what we've been doing for a long time. And so please, please, please reach out for help. We're more than happy to set up one call or a series of calls to help providers get ready for this. And so I hope that definitely helps. And I do just want to give everybody a little bit of an update on the ASAM alignment review. So in mid-March, the BIMCOs and some SCAs were provided a preview of the tool for ASAM level 3.5 and 2.1. And during those meetings, the BIMCOs and the SCAs were able to ask questions and engage in a dialogue with DDAP and DHS about the tool and the review process just in general. And so DDAP and DHS and the BIMCOs are still in a planning process with regards to how alignment reviews will occur. However, we are nearing the end of these conversations. We're still gathering some information, and reviews will likely begin sometime in the summer of 2022. So we are moving forward with this. It's been a long time coming, and it's definitely kind of picking up, and we will keep the field posted on these developments. But happy to say that we are starting to move forward with this. All right, switching gears from the ASAM alignment reviews. So this is one of those questions where I'm going to be asking for some participation. So this is going to be a time when, if you want to participate or you want to offer some feedback, this would be where you raise your hand. And Gloria is kindly helping me with this today, and we're going to identify somebody who has a hand raised so they can unmute themselves. So this myth here is something that we have heard. So it's not always, verbatim that this 1 hour of group therapy fulfills the daily clinical services requirement for levels 3.5 and 3.7, but it's similar, right? So we've heard things like, well, does 2 hours of group therapy kind of fulfill this requirement, or does one psychoeducational session and one group therapy in the afternoon fulfill that requirement? And so we really just wanted to kind of touch on this to give folks some information and some resources. So help me with that. So does anybody want to unmute themselves and talk a little bit about why kind of 1 hour of group therapy would not fulfill the daily clinical services requirement for these specific levels of care? And maybe you could even talk a little bit about what your program has done to implement these daily clinical services. So just going to wait here for a minute and see if anybody raises a hand. Paul says because ASAM requires 6. Ooh, thank you. And I see a hand raised here. Hold on 1 second here. I think this is going to work. Kimberly, do you want to unmute yourself and just offer some thoughts?
Yeah, can you hear me?
Yeah, I can.
Okay. So I know we're looking at potentially the 6 hours of clinical a day. What we've done in our program is we implemented the matrix group. So we do matrix for 4 hours, Monday, Wednesday, Friday, 2 in the morning, 2 in the afternoon. Tuesday and Thursday, we've implemented the trauma groups and our other auxiliary groups. But, my concern is we're still at the 4 hours a day, and clinically, my counselors don't have any more time to give to those. So my concern is for the additional 2 hours, is that something that we can have CRS run groups either in the morning or the evening, so we're in compliance with the 6 hours per day.
And Kimberly, do you all offer individual therapy through that time as well?
We do, right. So each client gets, the hour of individual services per week, although most of them have, 2 or 3, depending on, what their needs are. And they also meet with the medical staff, but, that's where we're a little bit nervous is, are we going to be able to meet that as an inpatient detox and rehab program?
Okay. Kimberly, thank you so much for being willing to be the first person to raise your hand and participate. I appreciate it. And I'm making a note here that we'll reach back out to you about your question with that. But that just offering your information about the matrix model and the trauma focused groups and the individual counseling, I think that's helpful in itself. So thank you for being willing to participate. Paul, I'm going to try to. Paul, can you unmute yourself?
He should be able to.
Perfect. Paul, are you still there? Lori, we try to unmute him one more time. All right. Paul, I think we're going to come back to you, but thank you for being willing to participate. So he said he's not able to unmute himself. Here we go. All right, Paul, I'm going to come back to you in a minute here. So just to kind of provide a little bit of an overview about why kind of 1 hour of group therapy or even kind of 2 hours of group therapy in and of itself would not kind of cover that daily clinical services requirement. So I'm simplifying the adult dimensional criteria here for 3.5 and 3.7 to really kind of simplify the point that I'm trying to make, which is that I think that when we look at this abbreviated list of patient characteristics appropriate for 3.5 and 3.7, almost all of us on this call can see why kind of 1 hour of group therapy or even 2 hours of group therapy a day does not fulfill the daily clinical services requirement. That would be really kind of doing a massive disservice to the individual. And if they truly only needed 1 hour of group therapy daily, they would be way more appropriate for ASAM level 1, maybe something different. But I think it all kind of goes back to looking at what those characteristics are for individuals needing this specific level of care or these specific levels of care. So I did include kind of the page references here for people if they wanted to look back to that. Paul, are you able to unmute yourself now and talk?
Yes, now the button is lit. Thank you. So yeah, the things we did, as we reviewed the ASAM, one of the things that we realized was that a lot of what we did fit into the ASAM description of clinical activity. So not just process therapy, what was clinical activity. Now, what this did require is that we write a lot more notes now, so that we are noting everything we do, not just the process therapy groups.
Okay. That is really, really helpful, Paul. And I think I'm going to actually flip to this next slide here as it touches on basically kind of what you said. When you look at the text and you look at that therapy section for these specific levels of care, I mean, there is a long list of kind of what can fall under the therapies that should be included in the daily clinical services. And so there's a lot there. And so I would really encourage people to take a look at those lists, because chances are you might even be providing these things already and you just don't realize it, or you don't realize that this is considered part of the daily clinical services. And so I think that that's really, really helpful to take a look at that. And we also did cover this during the therapies technical assistance call that we did in January. And so I just really encourage folks to kind of take a look back at that, that content, because I think that will help people as well. So, I mean, the idea here is that, patients don't need all the interventions listed on this slide, but the idea is that at the very least, these interventions should be offered, they should be available in case it would be appropriate for that specific individual patient and their needs. So hopefully that helps. Thank you, both of you, for being the first two kind of live participants during the call. I really appreciate that. All right, myth number 7. So kind of similar. Oh, Kyle goes back. Why are certain things circled here? So I'm actually going to go back to that. They're circled because I wanted to show a pattern. So you can see that in 3.1, 3.5, 3.7, and 4, these, they're circled because they all have that in common. Those levels of care all have those things in common, if that makes sense. And again, that slide and the other slides are available on the therapies ASAM TA call that is available on the DDAP transition, ASAM transition website right now. All right, so kind of a similar question. Offering only 9 hours of clinical services meets the requirement for an ASAM level 2.1 program. Same thing, and I'm going to ask for audience participation here as well. So if anybody is willing to kind of raise their hand, we will unmute you and you can speak. And I can go back to the question too, if that helps. So offering only 9 hours of clinical services meets the requirements for an intensive outpatient program. All right, I see a hand raised. All right, Rachel, would you mind? I mean, I think I just unmuted you. Are you able to speak?
Yes. the ASAM 2.1 level of care is for a range of 9 to 19 hours per week and should be individualized based on the person's needs when they are assessed and entering treatment, and should vary based on their needs throughout treatment.
Rachel, perfect response. Thank you so much for unmuting yourself and for speaking. I appreciate that. All right, I'm going to go through here. That is absolutely correct. So again, using some of the slides that we went through during the therapies technical assistance call that we had in January, Rachel was spot on. So the range is really 9 to 19 hours. It's got to be individualized to what that person needs. So not everybody is going to need the full 19. But there are going to be some folks that do. And so being able to provide up to that 19 is going to be absolutely critical. So I would say in such cases where somebody is no longer obviously needing that 9 to 19, that would be when they step down to a lower level of care. And so I also have here the kind of the list of what's included in those daily clinical services for these specific levels of care. So again, 9 to 19 hours has got to be that range. It just can't be that minimum 9. It's got to be the 9 to 19 hours based on what the individual needs, as what Rachel clearly stated. And again, provided page references for individuals or for folks to look at to see kind of what the therapies are that are included for each level of care. All right, so myth number 8, requiring counselors to be licensed or certified disqualifies individuals from lived experience from being able to work in the field. And so just wanted to kind of go through this. This is one that we haven't heard so much recently, but more so kind of in the beginning, maybe in the past 6 to 12 months. So this is absolutely not true. Individuals with lived experience, individuals identifying as being in recovery, are not disqualified from working as a counselor in Pennsylvania. The ASAM alignment requires appropriately credentialed treatment professionals. So this means that all individuals wanting to provide counseling services at licensed drug and alcohol treatment programs must be either licensed or certified or working towards certification or licensure. And that's a key piece here. So they either must be licensed or certified or working towards it. So there's some flexibility here, right? There can be a period of time where they're working towards licensure or certification. So this holds true for anyone wanting to provide counseling services, and it holds true for anyone completing a level of care assessment, regardless of their status of being somebody in recovery or not. So the other thing I just want to say here is that there are many, many, many skilled individuals currently working in the SUD treatment field who are not licensed and certified, and they are what we consider grandfathered. So this means that they, if they were working in their counseling position prior to July 1st of 2021, they do not need to move towards certification or licensure if they remain in their same position in the same organization. And so the other thing we just want to mention here is that obviously counselors must also meet the requirements in the regulations, which I have noted here. And these obviously were in existence long before ASAM came along, so we still need to honor those. This regulation explains that full certification as an addictions counselor by a statewide certification body, which is a member of a national certification body, or certification by another state's government substance abuse counseling board. I know that's a mouthful. The reason why I'm saying that is because it doesn't just need to be the Pennsylvania Certification Board. There are other certification bodies which will be accepted. And so I think that's something that we just need to remind folks of, is that there's that flexibility as well. So just to clarify, individuals with lived experience, individuals identifying as being in recovery, are not disqualified from working as a counselor in Pennsylvania. And again, there are many individuals who identify as being in recovery who are counselors, and they've done so much for the field, and they continue to, along with individuals who are counselors who do not identify with being in recovery. So more specific information on this topic and just the staffing in general can be found in the updated Pennsylvania guidance document, which is on the ASAM transition website. So we'll just encourage folks to take a look at that as well. All right, so myth number 9. All licensed SUD providers must apply for ASAM alignment or certification with DDAP. So this is not true. And I kind of mentioned this earlier, but just to remind everyone what this means is that in order to contract with the SCAs and the BIMCOs for ASAM level 2.5 and 3.7, so just these two levels right here, 2.5 and 3.7, providers must complete an alignment process with DDAP. So many of you on this call have been through this alignment process, so you know this firsthand, but this includes a review of policies and procedures, program schedules, looking at staffing schedules, job descriptions, and then an in-depth interview with an interdisciplinary team. So we basically put all that information together, and we look at that information against kind of what's noted in the ASAM text for that particular level of care, and we say, yep, this program is definitely ready. They're providing services in alignment with ASAM level 2.5 or 3.7, or they're so close, but there's this one area and they need some help with this. So we will provide technical assistance to get this provider in a spot where that they can be aligned. So this process is to confirm that a provider is in fact providing services in line with the service requirements laid out in the ASAM text. These are the only two levels of care this is happening for. This is not happening for other levels of care. It's not happening for IOP. It's not happening for 3.5. It's just these two levels of care right now. So I hope that is clear. Also just wanted to mention that the current lists of ASAM aligned providers for 2.5 and 3.7 are on the DDAP ASAM transition website, and our team, Gloria included, works hard to update this list at least every month, if not more frequently than that. So that is a real-time list of who has been aligned for 2.5 and 3.7. All right. So myth number 10 is that co-occurring capable programs must be duly licensed by DHS and DDAP. So many of you will remember that we did a co-occurring capability ASAM monthly technical assistance call. We did that jointly with our partners at DHS, and then Ifar also helped to present on that topic. And so we focused just entirely on co-occurring capability for that presentation. And so I would just encourage folks to take a look back at that if you're still having some confusion on this. But co-occurring capability and co-occurring enhanced are two different things. And so co-occurring capability does not require dual licensure by DHS and DDAP. Again, co-occurring capable programs do not require dual licensure by DHS and DDAP. So at this point in the ASAM alignment kind of process, really all licensed SUD programs should be either co-occurring capable right now or actively working towards co-occurring capability. So if you need help understanding this, there's a full list of items in the ASAM text on pages 26 through 28, which really clearly spell out what it means to be a co-occurring capable program. And again, we offered a technical assistance call on this topic in January, I believe January. So all the info from that call is available on the website. And just at its very most basic definition, co-occurring capable programs are those that have the ability, not so much to treat, although some of these co-occurring capable programs may be able to treat to some extent, which is great. So they have the ability to address co-occurring mental health and substance use disorder issues. So this does not mean that co-occurring capable providers, that they're the one providing the mental health treatment. Rather, this means that the program and the staff understand very fundamentally the interactions between substance use disorders and mental health. They know how to talk about substance use disorders and mental health. They know how to make the appropriate referrals. Patients are free to discuss both SUD and mental health issues, and there's no kind of stigma around that, or they're not told in group therapy that they can't talk about certain things related to their mental health. Individuals are not turned away at admissions because of their mental health issue. They are welcomed. So this means that policies and procedures, staff training, program content are all mindful of this reality that it is very likely that individuals seeking SUD treatments also have a mental health issue. And it's also very likely that the majority of individuals seeking mental health treatment have an SUD issue. So this goes both ways, depending on if the facility is a licensed substance use disorder or mental health facility. So just want to make sure that that is kind of something everybody understands. And again, please look at the content from our technical assistance call focusing on this issue a couple months ago. So I think I have gotten through everything a little bit early today. Let me just take a look at the chat here and see if there's anything. So just a couple of reminders is next month, we have a call scheduled for May 2nd from 10 to 11 a.m. And we do not know the topic for this call yet. However, we welcome suggestions. And in fact, if you have any suggestions right now, please type those in the chat box. And just want to remind folks that if you need technical assistance, please reach out to us via the ASAM email account. And please take a look at the ASAM transition page. I mentioned this last month, but this has been updated, and really encourage folks to take a look at this and to take some time going through some of the resources available. And I'm going to go back for a second to this slide. As people are leaving the call today, if you just want to take a look at some of the other topics that we've presented in previous calls, if there's any one of these topics that you felt like was really helpful to you, or that you'd like a little bit more of a robust presentation, then please type that in the chat box, and we can kind of we can maybe put something together to go a little bit further on that specific topic. And Paul, yes, do you want to unmute yourself? And I can try to respond to your question. If I don't have the response, I can get back to you. You can go ahead.
Give me 1 second. Let me find his name again. Sorry.
Okay, perfect. Thanks, Gloria.
System gets slow.
Paul, hang in there for 1 minute. I think he can unmute himself now.
Mm-hmm.
Thank you.
Yeah.
So yeah, Kathy, I have a question about with the training. So some of my longer term staff are thinking that only trainings that are, quote, approved by DDAP will fulfill the required training hours for ongoing staff. When I look at the regulations, it does for the mandatories of new hires in the first year or two, depending on your position. It does specifically say that these trainings need to be approved by DDAP, but I'm not seeing anything that says ongoing trainings need to be DDAP approved.
And so, Paul, this is not just ASAM trainings. You're talking about kind of all the trainings.
I'm talking right. Yeah. So this isn't just ASAM alignment, but well, I had you.
Yeah, no, definitely. So I don't know the answer to that, but what I'm going to do is I'm going to reach out to our training division and have them reach out to you. Yeah.
How about if I jump in and help?
Please, Jody, go for it.
So that depends on if you're a contracted provider. The mandatory trainings, HIV, TB, and STD are mandatory licensing trainings. The SCAs have the mandatory trainings that you're required to have if you're contracted providers with the SCAs. And then otherwise, your training plans that you have established with the individuals that you supervise, you can send them to trainings that you believe are appropriate and are needed for individuals. Does that make sense?
Thank you. Yes, it does. And I'll be honest, so that was my reading of it. Are we able to get that in writing? That will really help me with my compliance people, who they like to see everything in writing. They're funny that way.
Okay. Sure. It's two different entities. So, I mean, I can tell you it is in writing in the regulation what is required regulatory. So I can certainly send you that in writing. I'll point it out in the regulations. And are you contracted with your SCAs?
Yes.
With SCA? And that is in writing as well. I can send you both pieces. Do you want to put your contact information in the chat?
Will do.
All right. I'll get it to you probably later this afternoon.
Thank you.
You're
Thank you.
welcome.
Thank you, Jody.
You're welcome.
All right. So if anybody has anything else, I will stick around for the next 13 minutes or so. Otherwise, thank you so much for joining us again today. Such a large group again today. Just really appreciate it, and appreciate the participation. Thank you for being willing to try a different kind of approach today. And I think we'll try to do that in the next couple of sessions as well. So thank you. And again, these slides will be available on the ASAM transition webpage by the end of the week this week. Thanks, everyone. Gloria, if you want to stop the recording, you can go ahead and do that.